Okay, so this is chapter 43, and we are specifically going to hit on IBD. Not to be confused with irritable bowel syndrome. IBD is an inflammation process, and it's either caused by Crohn's or ulcerative colitis. IBD is the inflammation of your GI tract. So basically, we're going to start by defining it and then go through your symptoms, manifestations, different types, treatments, and so on. All right, so IBD is the inflammation of the bowel. Now you have two different types of IBD, but this is a chronic disease, right? It can go through periods of being active and then go into remission also. So certain things will upset it, but it is idiopathic, although there is some proof of it having been certain contributing factors. So it is idiopathic. All right, you have two different types. Like I said, you have Crohn's, and then you have ulcerative. Let me make sure I spell this right. Ulcerative colitis. All right, so you have Crohn's and ulcerative. With Crohn's, you can have it anywhere in the system. So it could be in any segment. Whereas ulcerative colitis is generally going to affect your colon. So with Crohn's, you're going to have any portion of the GI tract. Some of your symptoms are going to be weight loss, fistulas, stricture, so basically cutting off, perforation. Where do I go here? Perforation, which of course is going to lead us to peritonitis, but perforation and diarrhea, fever, malabsorption of nutrition. So diarrhea, fever. All right. With ulcerative colitis again is a little bit different and usually just affects the colon, colon or rectum, which just attach it. So with the ulcerative colitis, it usually only affects your colon, whereas this can affect the entire GI tract. Some of your symptoms with this are going to look very similar, and that could be confusing. But you're still going to have your diarrhea, obviously. Diarrhea. Here you're going to have, might have bloody stools, and as much as like up to 20 times a day. So bloody stools. Obviously you're going to have dehydration with the diarrhea. And one of the key things here is toxic megacolon, which, as you might guess, is an enlarged colon, which puts it as, and that's actually a complication, not necessarily a symptom. You might also have tenesmus, which basically is this urge to defecate, not necessarily, so you have a constant urge, or you have an urge to defecate, but not necessarily anything to void. And it's cramping. The cause for this can be autoimmune. So some of your causes can be autoimmune, and basically it's going to eat away its own tissue. So autoimmune issues, and then you have contributing factors. And note that I say contributing, not causing. Right? So contributing means that it's not the direct link. It's not the etiology of it. So contributing factors are going to be your high fat, high polyunsaturated fats, which are even worse, lots of meat, stress, smoking. It's more predominant in white, and especially people of Jewish background. So, so they've associated that a high fiber diet, high fiber, and of course there's lots of fiber in fruit if you don't know that, will decrease your chances of having ulcerative colitis, and Crohn's disease. Whereas vegetables will decrease your chances of having ulcerative colitis. So here we're looking at vegetables, and with your Crohn's, you're looking at fruit. Well, fruit and fiber, and really there's fiber in vegetables too, but anyways, so fiber and Crohn's and vegetables and ulcerative. So having high fruit and vegetables, of course, is going to be one of our treatments as well. Um, you're going to have weight loss with Crohn's. Um, there's usually going to be more weight loss in Crohn's than there will be in ulcerative colitis. All right, and then it puts you at high risk for cancer. So having regular screenings would be important, but it's going to put you at high risk for cancer and other complications. So again, just to reiterate, you have IBD, which is inflammation, an inflammation disease, not irritable bowel syndrome. Right, it's chronic. It has periods of exacerbation and periods of remission. It's idiopathic, but there is a autoimmune disorder where it goes and starts eating away its own tissue. It can be broken up into two different types. You have the Crohn's and you have the ulcerative. Your Crohn's can affect anywhere in it. All right. Where your ulcerative colitis is only going to affect, well, usually it's only going to affect your colon rectum. So with Crohn's, you're going to have significant weight loss, not as much in ulcerative. And you can also run the risk of having more fistulas and perforations, and you'll have diarrhea with both. With ulcerative, you're talking about bloody stools up to 20 times a day, so that's going to be an important test to run. You also run the risk of toxic omegacolon, and then the symptoms of or needing to constantly void. Stress is going to also increase this, and as you imagine, if you already have this, for instance, with the autoimmune thing, if you have the autoimmune thing but don't have any of these contributing factors, then you might not get it. All right, you could have all these contributing factors and not have the autoimmune issue, and you won't get it. So it's one of those things that you have to look at. But high fat, high meat, things that are upsetting, and of course, smoking and stress are always bad. It's more predominant in whites and juice. Fiber is going to be most important with Crohn's. All right, vegetables are going to be more important with ulcerative. So these are VU, which are kind of at the end of the alphabet, and this is FC, which are more at the beginning of the alphabet, if that helps you remember. All right, so let's look at some of the complications, and I'm going to continue to go back to the complications because they're kind of spread out throughout the chapter. All right, so complications. Some of the complications that we're going to have. Oops, that's one right there. Like I said before, you're going to have a high risk of cancer, especially the more you have it or the more exacerbations you have. You are going to have issues with your joint, and there's systemic issues. So joint, eye issues. You also run the risk of liver failure. Basically because your body is trying to filter everything. Some of the other contributing factors that I did mention here, contributing factors, other than your smoking and obviously your high fat, NSAID use, so lots of NSAIDs, diet, we already hit on that, and naturally that will be part of our treatment as well. And then that genetic factor, which I told you before, they've identified the gene as being NOD2. I'm not sure if it said NOD or NOD, but and environmental factors, maybe a high stress environment, things like that, and then of course hygiene. All right. So some of your complications: high risk of cancer, high risk for C. diff. All right. Joint, eye issues, liver issues, and then fistulas, but more so with Crohn's than with ulcerative. So fistulas are also a problem. There's a bunch of diagnostic studies. And let's see if we can't finish up with the contributing factors. Usually we try and start with the most invasive first. There's more contributing factors. Okay. So those are just some of them, and there is more listed in the book. But again, cancer, perforation is always going to be an issue and need to be something you watch out for, because once you have perforation, obviously you're going to have run the risk of peritonitis. So that's going to be important too. All right, so those are your contributing factors and complications associated with IBD. All right, some of your diagnostic studies. So diagnostic studies, we're obviously going to be running stool tests here. All right, we're trying to rule out other diseases. So rule out other diseases. All right, determine, and of course part of this is determine what type they have, and of course determine what type. So some of the things you can look at is your CBCs, and see where you are with that. A lot of times you might have a raise in white blood cells with toxic megacolon. You also might have blood in the stool, especially associated with ulcerative colitis. Because of that blood loss, you might also see some anemia or low iron in the CBCs. Stool tests, like I had said before. So we want to run those stool tests, see if there's any blood in there. And we're looking for blood or infection, bacteria. We're trying to figure out what's inside that stool. You also might see on your CBCs a low, and this has a lot to do with the loss of fluid, but low sodium, low potassium, low chlorine, and I know that doesn't normally go like that, but no low chlorine, low bicarb, and again, due to your nausea, vomiting, diarrhea, fluid loss, hypoalbumin, so low protein, and those are some of those ones that you would see in your CBCs. You can also do a contrast enema, MRI, or CT possibly. They might want to go in and endoscopically look at it. In the severe forms of ulcerative colitis, just to hit on that for a second, you're looking at tachycardia as being one of your things or your key signs, as far as something being chronic. All right. So some of the drugs and care for this. A lot of it for IBS, and there is a surgery. So again, our studies, you want to test our CBCs. We want to look at our white blood cells. We want to look at our sodium. We want to look at our potassium. We want to look at our albumin. We want to see if you have elevated white blood cells, maybe because of perforation or because of toxic megacolon. You might have anemia from blood loss. And you can do contrast MRIs and CTs. Again, there's always the option of going in there and endoscopically looking at things. All right. And so let's look at some of our care or treatment. And of course, there's a nutrition aspect, and then there's nursing implications, things of that nature. But our treatment. So we're going to treat the symptoms here. So we're going to rest the bowels, control inflammation. We might be looking at corticosteroid because we're not giving NSAIDs. Control inflammation, combat infection. So we're really looking at that infection and making sure it's not going to get into C. diff. If they are low in certain aspects, if they're low on the protein, low on the sodium, low on the potassium, we're going to correct that malnutrition. And they're going to need fluids probably. So just because of not the vomiting, diarrhea. And then try and work on stress management, because again, like I said, stress is going to play a part in this. Obviously, you want people to quit smoking. Now, as far as the drugs for these go, aminocyclates are some of the drugs. Let's see if we can put in here. That's this guy right here. All right. So some of the drugs that we're looking at, only half of my markers. All right. So some of the drugs that we're looking at, yep, that's better. Some of the drugs that we're looking at are going to be your aminosalicylate, which are going to result in yellow pinch skin. It would look like jaundice really because it's like yellow orange, but that's one of the possible side effects. Is that yellow skin, and it relieves the inflammation and trying to get that disease into remission. And of course, it's going to it's a chronic thing, so has a likelihood of becoming active again. Antimicrobiotics, and that's going to be to fight off any infection. And then corticosteroids, like I said before, corticosteroids, and that's going to help with some of the inflammation process here. Our ultimate goal is to try and get the patient back into remission. Okay. The immunosuppressants, and again, because there is an immune part here, so immunosuppressants might be used, but again, corticosteroids are going to do that. And you really have to watch out for infection at that point. The nutritional aspects of it, let's go over this before I erase it. All right, so your treatments for IBD, again, you're going to want to reduce the stress. You want to decrease the contributing factors: smoking, stress, high fat intake, malnutrition, and is going to be another important thing. And then some of our treatments are going to consist of what you would expect. Something to help the inflammation process, your corticosteroids, your antimicrobials to fight off infection, and your aminosalicylate, which are going to result in yellow or orange, but again, help try and get them into remission. All right, so let's look at the nutritional aspects of this. As you might imagine, if fats cause it, then we're going to try and take out fat. So the nutritional aspect of this is going to be increased calorie intake, because again, if you have inflammation for instance, if you have Crohn's and you have inflammation in all of your intestines, there's a high probability that you're not absorbing everything properly, and you're probably going to be needing a lot of calories. So that's their logic behind that. The increase in vitamins, again, having to do with the absorption. Increase in protein. We're looking for low residual things. All right, so low residual things. Obviously you want to increase your fruit and your vegetables depending on which type you have, and again, vegetables for the ulcerative, and then fruit or fiber for your Crohn's. The surgery is kind of your last treatment here, but we will go over that. And then you also have to worry about treatment for perforation. Okay, so if perforation is a complication, but if there is a perforation, our immediate things that we're going to need to solve, obviously, is we're going to have to start possibly draining, making sure that we're stopping infection, inflammation, things of that nature. So our surgeries, it's kind of our last stop resort. The surgery for Crohn's disease is going to usually be needed at some point. At some point during the disease process, you're going to need that. But it's going to remove part of the affected bowel. Unfortunately, this results in short bowel syndrome. So let's talk about that for a second. All right, so now we're on surgery and we're focusing on Crohn's. And again, Crohn's affects everywhere. Crohn's surgery So Crohn's surgery is going to remove part of the affected, usually the small intestine, but GI. So it's going to remove a segment of it. And of course, when you remove a segment of something, then you're not going to get that much more absorption. So you run the risk of being malnutritioned. You also run the risk of creating short bowel syndrome. And short bowel syndrome is where they've taken too many segments or too large of a segment out, and it's going to mean that they're going to need parenteral nutrition. They're not going to get any absorption. Obviously, they're going to have bowel issues at this point. If you've taken out a huge segment of the bowel, then things are not going to get processed or digested or absorbed the way that they should be. So you're looking at parenteral nutrition permanently after they experience short bowel syndrome. So with surgery with the colitis, you're looking at you're looking at an ileal pouch. So you're looking at the total removal of an area and diversion. So you can do that laparoscopically, but you're going to end up with some type of diversion for the type of pouch. All right, so depending on where they have it. Our nursing implications are going to be important here, and those are going to consist of rest and, of course, we need to address the diet factor. Perineal care, because if you have all of that going through, if you're having 20 stools a day, you run the risk of really having skin deterioration. And we have to explain to them the drugs and side effects and things that they need to watch out for if they were to have a perforation. And we already talked about the complications. Again, the fistula and C. diff. You need to explain all of that to your patients so that they understand. You also run the risk of gallstones. So this is just to name a few of the complications. Usually during your 6th decade, you have another exacerbation. So it could be in remission for a while, and then you come on your 60, 61, and all of a sudden you have an exacerbation of it. So again, don't confuse this with IBS. And that is as far as we're going to go with that one. So that's your Crohn's surgery. Look at the complications of that, and we will go into the rest of 43 on the next video.